Jimmy for inviting me to this my first Grand Rounds. I'm a long-time listener, first-time caller, as they say. So glad to be here. Unfortunately, we have 6 more weeks of winter, but we're going to try and make this a bit warmer of an occasion. So I'll be talking a little bit about the work that I've been involved in for a number of years now about financial decision making, particularly in the mild cognitive impairment stage. I have nothing to disclose. It's a problem that I've been working hard to change. Hopefully the next time I come back, I'll have this slide a little bit fuller. Um, I'll try over the next 30 minutes or so to paint as wide an arc over the topics that are important to financial decision making. First, starting out by expressing how distinct and clinically meaningful the concept is and how it's related to things like functional independence, vulnerability to exploitation, and dementia risk. Second, we'll take a look at some of the research I've been able to generate over the last few years, integrating some of the behavioral and neuroimaging findings that link financial decision making to specifically neural systems. Third, we'd like to take a look at how financial decision making in particular is related to global cognitive decline and even becoming a marker for predicting progression of the underlying diseases. And finally, because we're all clinicians, we'll take a look at what it is about financial decision making that we need to be aware of in the clinic space. We heard a wonderful presentation from our guest patient here today, but I'd like to give you a couple of others. A case 2 is of a 70-year-old woman previously diagnosed with MCI. When we first saw her in the clinic, her Mini-Mental State Exam was a 26 out of 30. She was physically healthy, no neurological injuries. Her clinical brain scan was otherwise fairly normal. Her FDG PET scan, which we got because we couldn't come up with any signs of atrophy on the clinical MRI, was positive for frontotemporal hypometabolism. More socially disinhibited is what she became over the intervening years. She became more impulsive. She started answering phone calls from scammers, and then unfortunately started giving out her personal information, including her social security number, bank account, and routing numbers. 1 year, unfortunately, she fell prey to a scam and lost $18,000 as a result. Case 3 is of a 73-year-old man. He had no prior cognitive, neurological, or psychiatric problems. He was near retirement and as a result was planning his retirement life in his home country. And after a trip there on the way back, he was quite jet lagged and got a phone call the next morning from somebody who said, "I'm going to turn off your power." I'm from the electric company, Pepco, in the Washington, D.C. area. And if you don't go to the nearest 7-Eleven and buy gift cards totaling about $750, I'm going to turn off your electricity. He did it. Gave the person on the phone the codes to the back and lost that amount of money. As an aside, he loves to eat hot dogs and is a big fan, as am I, of the Washington Commanders. This person was my dad. So we can make the observation that older adults have problems with financial functioning, regardless, unfortunately, of the type of functioning, the condition that it comes from, even if it's normal, and the severity of it. And that begs the following questions of not so much who and what, since we have a good sense of what that is, but how and why. And those two questions beg the investigation of what the neural mechanisms are that contribute to the impairment of financial decision making within the context of cognitive disorders. So I think it'll be helpful to begin with to take a wide-angle view as to what exactly is happening when we talk about what the underlying pathologies are of these different types of conditions, and whether you have A beta and tau accumulation in an Alzheimer's process, or synucleinopathy like Lewy body disease, or TDP-43 or tau accumulation in frontotemporal dementia. All these neurodegenerative conditions seem to come down a common final pathway in which behavior and cognition are impacted that lead to a loss of function. And the functioning is what we typically call activities of daily living, basic ones like dressing and feeding yourself and bathing, to more complex ones, of course, like financial decision making, taking your medications, driving. And when the underlying processes continue to progress, it leads to loss of even more function, leading to loss of independence, and then a number of other negative outcomes, including caregiver burden, becoming institutionalized, and even having physical limitations. So the hope in the field has been to develop treatments, either pharmacological, like cognitive training, non-pharmacological, pharmacological training like the anti-amyloid therapies, non-pharmacological ones like cognitive training that might stabilize this descent into loss of independence. Also, at a high level, since we talk a lot about Alzheimer's disease, we should remember that it is a progressive disease in which there are a number of biological changes, starting with the accumulation of amyloid protein and tau, typically in the pre-symptomatic phases when individuals show no symptoms of cognitive dysfunction, and then progressing to the changes to brain structure and function. And then, of course, in the milder phases, progressing into more advanced phases to dementia syndrome, having more obvious and being able to elicit cognitive symptoms, and then becoming ultimately much more obvious in a clinical standpoint. So what does this mild cognitive impairment have to do with it? We know that in the field, we've been looking for earlier and earlier phases of the disease to which we can become more impactful, that is to stabilize the underlying condition. And the definition of the condition very simply is that it is an objective change in cognition that is not dementia with overall preserved daily function. We found out that aside from having the cognitive changes that we can sometimes find, there in fact is decline in everyday function. Almost to a third to a half of individuals have some form of subtle and early cognitive impairment. And these types of impairments, even though the individual is still independent, cause decreased quality of life, appear to be a burden on social structures around them and resources, and certainly cause stress to caregivers. In the clinic space, it's a difficult proposition to be able to distinguish somebody who has mild cognitive impairment from dementia for the sole reason that there isn't good objectable signatures, biological or otherwise, that differentiate one from the other. And so in our notes, we oftentimes write that this individual has daily functioning that's grossly intact or only slightly abnormal, and this is really quite unsatisfying for clinicians like us. So mild cognitive impairment is really an opportunity for improving definitions, detection, and intervention, and I'll go on to talk about how we can do that with understanding the underlying biology and biomarkers. So what about financial capacity? Of the ADLs, FC is one of the most commonly studied and is unfortunately one of the most important from a social standpoint. Dan Marson at the University of Alabama has taken the very first steps in understanding and characterizing this particular construct. And we know that it involves conceptual, pragmatic, and judgment skills altogether. Like you've already heard me say, it starts in the MCI phase and worsens over time and includes complex skills, ones like our guest has been talking about, investments and conceptual knowledge about financial areas. And then more basic ones too, where you have skills like counting coins, prioritizing bills, and things of that nature. Older adults, as they decline in the progression of their underlying disease, may have problems with one or both, but certainly the basic skills tend to be impacted the last, so in more advanced phases of the disease. The financial capacity instrument was developed about 20 years ago by Dan Marson, and is considered the gold standard in assessing decisional capacity. It is a strong indicator of caregiver burden, and there was a report from the Institute of Medicine in 2012 that identified it as such. In everyday life, we know that individuals with major capacity concerns can lose a lot of money, like I've already described, and there have been estimates that put that amount to up to $30 billion per year that's lost in scams and victimization. This is a table of the underlying concepts that are accounted for in the financial capacity instrument, the FCI. They include domains such as basic money monitoring and skills, things like counting coins, identifying currency, financial conceptual knowledge, identifying major concepts like investments and debt, cash transactions, being able to demonstrate how you effectively purchase an item, a one item or two item or three item process, managing your checkbook, and a number of other ones, including understanding what is, how to detect fraud in a mail scam. So over the years, there have been a number of groups, primarily in Dan's lab, that has identified what the underlying nature is of financial capacity, and that has included cognitive constructs, anatomical ones, And the cognitive nature of financial capacity primarily centers on executive function. Ozioma Okonkwo, who is now a professor at the University of Wisconsin, who was here in Maryland's lab for a couple of years, did a very nice study that identified that selective attention, self-monitoring, and working memory are highly related to financial capacity as assessed by the FCI. And a number of individuals from Dan's lab, including Griffith and Luke Stokel, who actually happens to be my program officer at the NIA, have identified that the FCI is strongly related to areas of the prefrontal cortex, the angular gyrus, which we'll talk about in a second, and the precuneus. Specifically, these are atrophy in these regions. And then it's been hypothesized that more anterior regions, like the prefrontal cortex, for example, are responsible for more complex types of financial functions, and more posterior, more basic types of functions we'll talk about as well. More recently, there's been metabolic work from the ADNI study, which you've heard about, associating A-beta and tau accumulation in very sensitive areas of the brain related to Alzheimer's disease with financial capacity as well. What I'd like for you to take a look at here is the fact that these different areas seem to overlap quite nicely with the executive functioning network. And I want you to remember the word network because we're going to talk about that quite a bit. So for such a complex dynamic function like financial capacity, it's good that we've been able to establish fairly static measures of the relationship with brain structure. But we need a much more dynamic measure, and that is connectivity. So in my research, we've been able to look at resting state connectivity with fMRI that identifies active cortical hubs using the BOLD signal as a proxy for brain activity. And using analytical techniques such as seed-based connectivity and independent component analysis, we can look at what other brain parts or regions are related in a synchronous way to place in the brain a region of interest that we plan to seed. And then we can look at those regional hubs in the cortex and connect them, sort of like connect the dots, with diffusion imaging, diffusion tensor imaging in particular, which identifies the strength of connections by white matter integrity between hub to hub. And what ways that we measure that is with measures of fractional anisotropy and mean diffusivity. And these are measures of how water moves across these longitudinal bundles of white matter. So this is a bit of a didactic aside, but over the years, behavioral neurologists and neuroscientists have been able to establish functional large-scale networks. Probably some of the best that we've studied, Dr. Rose and I, in Marcel Meselem's work, the esteemed behavioral neurologist who identified these networks primarily in primate models with pathological examination. He identified 5 large-scale networks, one being one for spatial attention, another for language networking, one for memory and emotion, one for executive control, and a 5th for face and object identification. Bresler and Menon in 2010 had a foundational paper that was built off of resting state fMRI that identified 3 core mechanisms for how the salience network, the executive control network, and the default mode network interact with each other, hypothesizing that the salience network operates in the form of a switch, turning up and down the executive control and default mode network, depending on both internal milieu and experience as well as external and environmental factors. So that leads us to the work that we did in the K, so I'll present some of those data here. Very briefly, we recruited 2 groups of patients, one cognitively normal, the other one with mild cognitive impairment. They were over 65 years old, had 12 years of education, and met criteria for those who had MCI, for MCI. We tested their cognition using the NAB, the Neuropsychological Assessment Battery. We assessed neuropsychiatric symptoms, and we consented them to performing the financial capacity assessment, but in this case, the short form that measured functioning over 4 domains: financial conceptual knowledge, use of a bank statement, monetary calculation, and operating a check register. And of course, we had imaging studies that we conducted, including resting state fMRI and DTI. These are some results. What I'd just like to point out here is the fact that the 2 groups separated quite nicely, specifically on areas of the FCI. And to take note here that there are two scores that you can get on the FCI. One for the total score, how you perform accumulating points for correct answers, and one for completing the test in a certain amount of time. So we keep track of timing on those tests as well. Remember that as we go through the slides. And of course, they obviously, separated nicely on other cognitive domains like the HVLT, the Hopkins Verbal Learning Test, clock drawing, Trails B, and animal fluency. We looked for relationships between the FCI and cognitive measures, and we did linear regressions to look at these associations and found that two measures, specifically the Mini-Mental State Exam and the Trails B, were significantly associated with the FCI. Trails B, as you might know, is a measure of executive function, and sub-processes under the executive function domain include items such as attention, visual search and scanning, set shifting, problem solving, and abstraction. These are results from the resting state fMRI analysis, and what I'll point out here is that we planted the seed region in the left angular gyrus, that region specifically because it's highly implicated in number processing, and look for other correlated regions around the brain using seed-based analysis. That resulted in 26 brain regions that were significantly associated, and of those, 14 were associated with higher order cognitive function and carried forward in the analysis. And what we found then is that the temporal fusiform cortex was highly associated with the left angular gyrus, and then those two with the financial capacity instrument. So the temporal fusiform cortex, let's talk about that for a brief minute here. As you might or might not know, it is an area of the ventral visual stream that is involved in higher order processing of visual information, specifically of color and face, body and word. It also has strong relationships to memory function, multisensory integration, and perception. And you see deficits in these functions and conditions which produce prosopagnosia, the ability to recognize faces, synesthesia, and dyslexia. It also has a fairly strong functional relationship with the angular gyrus, which is known to be involved in number processing, word reading and comprehension, activity within the default mode network, and memory retrieval. And we see that when there's focal damage to this area, the angular gyrus, that produces the Gerstmann syndrome, agraphia, left-right disorientation, finger agnosia, and dyscalculia. So you might remember when I showed you how the two groups in the study separated, that to put a placeholder on completion time, which is also kept, that we also record in the FCI. And we wanted to understand what it was that caused that group separation. And we hypothesized that it wasn't so much the activity of the cortical hubs, but it may be the white matter integrity between the regions. So we looked at the completion time and looked at associations between that and white matter integrity. And we found that white matter bundles or fascicles, such as the inferior longitudinal fasciculus and the vertical occipital fasciculus, white matter bundles that are important in visual recognition, semantic processing, and interhemispheric communication were highly related to the FCI. So overall, these results showed that these white matter changes represented inefficiency and slowing in conducting the types of tasks required from the FCI. The study was actually started and completed by Dan Stevens, who was a former resident and fellow here at the program. Still interested with the timing component on the FCI, we did a secondary analysis of a large cohort that you've heard about already, the ADNI study, the Alzheimer's Disease Neuroimaging Initiative. It had a total N of 874 participants, all of whom completed the financial capacity instrument. And we wanted to know is what were the factors that led to conversion from normal to mild cognitive impairment or Alzheimer's disease. And we found that those individuals who were in the slowest tertile of individuals were 4 times more likely than anybody else to convert from normal cognition to MCI or Alzheimer's disease. So again, some converging lines here that show that the timing component of the FCI is incredibly important, and therefore may be something to keep track of in our patients. So to summarize briefly, we found out that with resting state fMRI, we have a functional connectivity measure between the angular gyrus and the fusiform cortex that was responsible for some association with financial decision making. Diffusion imaging tells us about the white matter interactions and the integrity between hubs. ADNI showed us that slowed performance on the FCI predicts progression from one disease state or diagnosis to the other. And while these are very helpful, we know that these measures only identify what and who is at risk, not so much how making decisions related to finances break down in real time. And so to identify and understand this mechanism, we must move from static measures of metrics to dynamic decision processes. And that's the progression from this form of research to understanding active task-based fMRI that we can pull apart to identify valuation, learning, and risk sensitivity, as well as cognitive control in one instrument. That instrument is the Iowa Gambling Task. It's an oldie but a goodie. Many of us have studied here. It's been around for a long time. And as many of you might know, the IGT models real-world financial decisions by requiring learning under uncertainty, balancing short-term gains against long-term outcomes. The task works in two phases. One, making a choice, and secondly, evaluating an outcome. So participants are, in this case, in a scanner, and presented on the screen in front of them are 4 decks of cards. They're asked to choose a deck of card and to understand what amount of money they either gain or lose, and through successive trials, they start to learn which are more profitable for them. And during this task, what success represents is that they're able to effectively use valuation, risk monitoring, and cognitive control that will bear them a better outcome at the end of the task. There have been a number of studies over many decades now that have shown that this particular process maps nicely onto neural circuits representing all these 3 canonical sub-processes: the ventromedial prefrontal cortex for valuation, the anterior insula for risk monitoring, and the dorsolateral prefrontal cortex for cognitive control. So we did something about that. We completed a very small pilot study for a grant application. We successfully implemented a IGT protocol in MCI, first of its kind actually. Never has been studied in patients with MCI in the past. We recruited a total of 6, but we were able to analyze data from 2 normals and 3 individuals with MCI. And with their performance on the financial capacity instrument, the MCI participants, as will come as no surprise, performed more poorly, had lower total scores, and were slower on real-world financial decision-making on the FCI. When analyzing the fMRI data, we were able to show that those individuals who had MCI compared to normals had qualitatively different neural responses in those 4 regions. So now what? There was a wonderful paper by Wadira et al. That established how primary care physicians should approach individuals in their clinics, since they take most of the patients who are of old age, and how to address loss in financial capacity. And they have a very nice stepwise model for how you bring up questions and assess this. And there are general questions that you can ask, such as who manages your money? Do you have anyone besides yourself or who manages your checking account? And you can progress to more specific questions, such as, are you having any problems with making change? When was the last time you were late paying a bill? And things of that nature. What I want to impress on you is that we can ask even more questions now, generated and fueled by the science, where we should be asking things about processing speed. Are there decisions that you have to make under duress or increased complexity or uncertainty? And are there executive control issues, executive functioning issues that we should be talking about in the clinical space? Things like attention, visual search and scan, and things of that nature. So what do we do about it? For our patients in our clinics, certainly before the point of impairment, it's important to be able to assess whether there is a durable power of attorney. And then after impairment, educating patients and their family members, recommending practical interventions such as setting up safeguards with banking institutions, for example. And then finally, when there is gray zones, referring for formal financial capacity assessment, typically within neuropsychology departments. So what does this all mean in the grand scheme of things is that with the science, my hope is that we can help first stratify early identification of these problems, identify this in individuals that are at heightened risk, and using the biomarkers and behavioral data that we've collected to sort those who are likely to fall prey to scams, for example. If we're able to do that, we can also inform caregivers and system level and put into place system level safeguards to help protect these individuals. We can also put into action targeted cognitive and decision training interventions, things like cognitive remediation, training, feedback learning, strategy maintenance, and there are programs to improve cognitive control and executive function. And what's especially exciting to me is that we can use techniques like neuromodulation, even that are going to deeper levels and deeper cortical structures to alter the activity of those regions in the brain, and also pharmacological interventions for circuit-specific chemistry. So where are we going from here? Vidya Kamath and I, a few years ago, dreamt up a paper to make the case that we should be testing many more people in the clinical space. And so we've been working slowly but surely on developing a screening measure that can be put into higher technological forms. The picture up there that you see is what the financial capacity instrument looks like now. I've been told that there is actually an electronic version of that that's been developed, but is currently being validated. And so we need better ways of assessing financial decision making in our patients. I'm also interested in how transdiagnostic investigation might work out. Clearly, in psychiatry, we have conditions where people become impaired, schizophrenia, bipolar patients who spend excessively, for example. There may be interesting parallels we can draw with neurodegenerative disorders, specifically around everyday function that may have common biological markers. And as I mentioned, we have interventions that now, and hopefully in the near future, will be based on empirical findings. So a big thank you. I think I'm finishing about right on time to a whole host of individuals. These are just some of them. I want to thank the NIH for funding the K23 award. I'd be happy to thank them again for an R01 award, but that is yet to be shown. So thank you again for your attention.
Thank you, Dr. Narangi. That was very interesting. Of course, it's such an incredibly practical issue. It's so important. It's so crucial to people's well-being as they get older. And I guess I'm thinking about this whole financial scamming issue. I suppose there are a number of ways in which it's practical, but I guess elders getting scammed is a pretty darn common thing. And at the end, I guess what I'm thinking about is this question of, should it be standard practice that older people get this sort of financial assessment that you were talking about doing with Vidya at the end? I guess it seems like something that's not hard to systematically test. Can people make sense of a bunch of financial issues? Right. Should people be routinely tested, and if don't achieve at a certain level, should they be pushed to hand over decision making to someone else?
Well, you certainly got my vote for it. The FCI is a 15-minute exam, and it takes administration. And you have to have a person to administer the test and to administer the stimuli. So I think one fairly low barrier, especially with new technology, is developing an electronic version with technology that's able to assess, be able to deliver a task, be able to interpret the findings, and then integrate those into some sense of an assessment. So we need to pick up steam in this assessment tool that we've dreamed up. But yes, I mean, I think there's wide-ranging implications for not doing it. Certainly $30 billion has been sort of on the low end of the amount that's even reported. That's not to account for the amount that's lost for those which is not reported, typically from friends and family. I've gone through it, with older aunts and uncles who have passed away and seeing how their children fight over resources and things of that nature. So rolling it out into primary care situations with doctors being able to do this very simply as patients sit down in the waiting room to complete, I think would be very helpful.
Thanks. Let's see if other people have questions. Dr. Sloan, is it? Yes.
I think that's,
You want to repeat the question?
again, yes.
No, you want to repeat
Yes,
the
please.
question?
Yeah, go for it.
No, I'm saying, can you repeat the question? And can you repeat the question you heard
Oh,
into the
want me to
microphone?
repeat it, yes. So if I understand it correctly, it was, do patients essentially perform too good for the test and are able to squeak by as a result of their intelligence? Did I hear that right? Okay. So I think that's a great point. The test itself doesn't seem to have a ceiling effect, like statistically. And so we get good spread statistically over individuals with mild cognitive impairment. That being said, you raise another really interesting point about compensation. Individuals, perhaps even like our guests, may be having mild problems with it, but use more sophisticated, previously accrued knowledge from financial concepts, for example, learned behavior, to cover up for smaller mistakes. So yes, that is something that has been looked at. Dan Marston's group took a look at it and saw if there was any ceiling effects to the instrument. There doesn't seem to be.
Interesting. Dr. Morrow. I'll repeat that one. Can you talk about different underlying reasons for financial issues like disinhibition on the one hand, forgetfulness on the other?
Yeah, so I think you raise a really interesting point. Some of the data we didn't present was the effect of mood disorders on financial decision making. Impulsivity, disinhibition in particular, are ones that we didn't find as prominently in the ADNI study, but that doesn't mean that they don't exist, right? Interestingly, Greg Pontone, who we talked about briefly before the talk, now at the University of Florida, has a budding relationship with Natalie Ebner, whose work has been primarily in detecting susceptibility to scams. She has a deception task. And they want to study it in patients with Parkinson's disease, who, as a result of having dopaminergic effect or increased dopaminergic tone, may have increased disinhibition, for example. Certainly we can see it in frontal cortex disorders like brain injury, frontotemporal dementia, and things of that nature, but we don't do a really good job outside of Alzheimer's and MCI to look for those.
Thanks. Other folks? Dr. Barisas.
Yep.
Can you talk
Yep.
about the social domain element of social awareness element of financial problems?
It's a great question. Good to see you, Derek. You've grown out your hair. Looks good on you. It really speaks to the breaking down of what financial decision making actually represents. On the one hand, certainly there are complex skills that require a fund of knowledge. Okay? Often we call that crystallized knowledge. There's also a functional part to it where we have to execute on a particular skill, like writing a check, for example. And then you bring up a couple of other issues, which is what is the social context for which those decisions are made? Certainly we have a Western social context here. Other parts of the world may have others. And then there's the other part of it is trust and how that may erode or build as you get older. There have been a number of groups that have looked at things like social cognition, for example, certainly in FTD patients, that have looked specifically at that, but not in the relationship to financial decision making, but it's an area that needs to grow because it's a more multifaceted construct than just what I presented today.
Dr. Hingle.
Yeah, the last question is no.
You
There are
want
no.
to just repeat that or
Repeat it? Sure.
summarize?
Yeah, great. So another great question. The question was about the hazard ratios that we had in the ADNI study. It was striking. And the question was about whether they were controlled by global cognition or other measures. I'm adding to this, other measures of psychomotor speed. And the second question was about were there any more or other instruments? So the answer to that is no. There weren't any other instruments for financial capacity or decision making or other decision making. But to the first, I think that's a really astute question. And so we know that as patients get older, they naturally have slower psychomotor speed. And so the statistical model accounted for that. We entered in global cognition in the mini-mental as well as TRAILS B as a proxy for psychomotor speed.
Well, maybe I'll ask one. Oh, was there another? Go ahead.
So this is a question about whether there's a protective effect for married individuals who are aging. So I'll answer that anecdotally. And in the clinic, we see individuals who have most problems who typically have a spouse that passed away and who manage the finances or whether they did it correctly or together. So I can only surmise that there is a joint financial decision-making process that happens within the context of a married relationship. And so we see this in other ways too, but individuals who have a spouse that passes away, for example, may be responsible for learning the passwords or doing something they didn't do before or buying the groceries, which they've never done before. I'd be that way. So yes, I think that's a very interesting question as to what that relationship actually looks like.
Thank you, Dr. Narangi, for a great round. Very interesting.